Dear faculty and delegates, ladies and gentlemen, with your permission, I'm going to start this the unique webinar and titled as 10 Most Impactful Landmark Publications in Gastroenterology. I had an idea, why not? We always learn and update ourselves with the didactic lectures, symposia, and so on. But when I go for rounds with the postgraduates, I ask them who has contributed in the GA bleed, or who contributed in endoscopy imaging, and so on. What are the landmark where we have really changed the direction? Some people come forward and knowing the history. Some people may not be able to tell it offhand. So I thought every gastroenterologist should know 10 most landmark publications impactful in gastroenterology in every subspecialties. That is the one mooted the idea. And so with this idea, we thought we will all we welcome all the delegates and faculty. This webinar series and great news is endorsed by American College of Gastroenterology and Tamil Nadu Medical Council and Tamil Nadu Dr. MGR Medical University. And this has been organized by MedIndia Hospitals and Academy, Chennai, India. The institution is affiliated to the local medical university. The name of the university is the Tamil Nadu Dr. MGR Medical University. The series 1 started with the stalwarts like Professor Sareen, Dr. Nageshwar Reddy, and my colleague, Dr. Vineet Aguja. And we started like that in a broad spectrum topic like endoscopy, hepatology, and luminal gastroenterology. Over 3,700 delegates attended the webinar. Then I thought this is very inspiring to me and to the delegates. We moved on to the second series on small bowel, and the speakers were Dr. Mahesh Goenka and Dr. Govind Makaria, and moderated by Ajay Kumar, Mohan Prasad, SP Misra, and so on. The third series was in pancreas by Dr. Pramod Garg, Dr. Amit Medyo, and Matthew Philippe, Ramesh Ruproy, and Dr. Jayanti. The fourth one was in hepatology and hepatitis C and non-alcoholic hepatitis, steatohepatitis by speakers Anil Arora and Akash Sukla, and moderated by our own colleagues Venkatakrishnan and Ubaldas and SP Singh. Now, having thought this is from national, we'll move on to the international webinar because we found a lot of delegates from all over the world, particularly the Southeast Asia and the Gulf countries, and US started attending this webinar. So we converted as an international webinar. So we really requested for the endorsement for ACG, having seen the merit, they endorsed our international webinar. This is going to be 4 webinar series. This is the first of the international webinar, and this is happening today. And we welcome all the faculty, Professor Hiroshi Oido from Osaka Institute, Japan, and Professor Dr. John Salzman from Brigham and Women's Hospital, Harvard Medical School, USA. We have eminent panelists, Professor Nalini Gouda from Wisconsin University, Milwaukee, and Vivek Kaul, professor, and from University of Rochester Medical Center, New York. And this whole session is going to be moderated by my colleague and good friend, Professor Dr. Vivek Saraswat, SGPGI Lucknow, and he is the president of Indian Society of Gastroenterology. Our forthcoming series have been already lined up, and this is going to be on GERD in Barrett's esophagus by Professor Pratik Sharma, and bariatric treatment from my friend, colleague, and from Brazil, Professor Manuel Galvio. He is the authority in bariatric treatment, and it is going to be the panelist, Professor Prasad G. Iyer from Mayo Clinic, Rochester, and Mohit Bhandari from Indore, and Dr. Rakesh Kalapala from AGA, Hyderabad. And a 7th webinar on biliary disease, Professor Todd Barron from University of North Carolina, USA is going to talk on biliary diseases, stone and stricture. Again, I just want to tell you about all about the landmark publications, and myself will be talking on biliary endotherapy, and Professor Richard Kojarek, who is a senior most gastroenterologist from USA, from Seattle, is going to be the moderator. Dr. Murthy Badiga, again from Texas, and my own colleague Randir Sood from Gogan, India. He is from Medanda Institute. He is going to be the panelist. The last of the webinar series, international webinar, this is again very exciting topic, going to be third space endoscopy by Professor Noria Fukami from Mayo Clinic, Arizona, USA, and interventional US by Professor Dr. Kenneth Binmolar. He is from California Pacific Medical Center, USA. Again, we have excellent panelists here. Professor Mustafa Ibrahim from Cairo, Professor Amitabh Chak from the Ohio, and Amal Bapai, my own colleague, and Dr. Sandeep Lakhtakia from Hyderabad. So with this, we don't want to stop it here. The proceedings of the 8 webinar series will be published as a book, and we are very happy to give a complimentary copy to our ISG members and SCG members of this region. And you will get a CME credit hours of Tamil Nadu Medical Council, and the certificate of participation. You'll get an e-certificate once you apply for it, or just email it to us. We'll get the certification also. And this has been possible because of the constant efforts and the dedicated services offered by my colleagues, Dr. Satyamurthy, Dr. Raja Yogesh, and Dr. Gokul, Dr. Prasad, and Dr. TNS intensivist. Nothing is possible without the academic partner. I must really congratulate and thank our academic partners, that's Micro Knowledge Academy. With this small introduction, I thank you very much. You can log on to my website or the lecture series at medindialectures@gmail.com if you want any clarification on the slides further. Now I have a very pleasant task to introduce Professor Vivek Saraswat. Vivek Saraswat is a busy academician. He is a professor and HOD, Sanjay Gandhi Institute of, one of the premier institute of India in gastroenterology. And he is the professor and head, and he is the current president of Indian Society of Gastroenterology. And I have a great pleasure in interacting with him. He is one of the most active person in the field of gastroenterology in India, and his communication skill, I always enjoyed it very much. And he is the head of the department, as I said, and he is the past president of Indian National Association for the Study of Liver. He is one of the most articulate gastroenterologists of our country. He has been awarded several prestigious awards, the most prestigious being Dr. B.N. Berry Fellowship, and he has been the fellow of Royal King's College Hospital, London. He has been trained in therapeutic endoscopy. He's an all-rounder, and esophageal manometry. He is at one end luminal and endoscopy and liver. He has published over 200 papers in international and national journals, and contributed for the book chapters also, and been the associate editor. And as you see, his various of interests are so wide-ranging. And above all, he is very humble and simple to communicate, and he is very prompt in delivering whatever we request him. And it's a great friend of mine. And I request Professor Dr. Vivek Saraswat to moderate entire proceedings of this. Professor Vivek Saraswat. He will be introducing both the moderators now. Apart from this, his thoughts about these landmark webinars being conducted by MedIndia Hospital, he would introduce the Professor Vivek Kaul and Professor Nalini Guda. And in turn, these moderators, the panelists, both Vivek and Nalini, will be introducing the speaker. The first speaker will be Professor Noria. Now I'll hand over the mic, literally the mic, to Professor Vivek Saraswat. Thank you very much.
Well, thank you very much, Dr. Chandra Shekhar. It's been already it's been a pleasure being part of this session. I've looked at your concept and the way you have thought all this out, and I must say that it bears typical TSC signatures. All of us in India know you as TSC, and flamboyance and the panache that goes with your style of presentation, whether it is in slides or whether it is in person, accompanied by very meticulous attention to detail. I think all of us on this panel will vouch about for the series of emails and communications and instructions we've been receiving for the last several weeks about how we go about what our roles will be. And so it's been a pleasure, the build up to this meeting, and I really seeing the towering figures who are being chosen as the panelists, not just in today's, but in the subsequent international seminar webinars. I'm very sure all the delegates will thoroughly enjoy being part of this series. With these few words, and once again, congratulating you on the concept and the novel, original thought of getting these landmark publications out in the form of a textbook, so that there is a lasting piece of or some a book or literature in the hands of students as of 2020. What were the landmarks in these very important areas in gastroenterology? So great thought, well deserved. So with these few words, I'd like to get the session moving, and would like to introduce the uh, panelists for the evening. So if
We call.
right. The first panelist is, while a slide comes on, it's a great pleasure for me to introduce my namesake, Dr. Vivek Kaul. We just met this evening on this panel, and Dr. Vivek Kaul is the Segal Watson Professor of Medicine and the Chief of Gastroenterology and Hepatology at the University of Rochester Medical Center in New York. He has clinical research and medical education efforts that are focused on therapeutic endoscopy, interventional EUS, advanced ERCP, as well as endotherapy in the esophagus for Barrett's and esophageal cancer. Again, two diverse ends, the biliopancreatic and the esophageal. He co-directs the developmental endoscopy lab at the URMC and has served on several national committees with the ASG and the AACG. He chairs the ACG Innovation and Technology Committee and the EUS Special Interest Group for the ASGE, reviews for several journals, and has authored several publications in the field of interventional endoscopy. And we look forward to him introducing Dr. Oido, who will be the speaker for the first one. I think we can
Yeah.
move on and maybe
Yeah.
also introduce Professor Nalini Guda at the same time, so that we do not have to come back to
Okay,
this
okay,
in the
right.
later
That's
part.
a good idea.
Or if you would like to, we could do that.
Yeah, I would like to see you once more like that.
Yeah.
No problem. Okay.
Okay.
Already ready now, Nalini Amguda.
Right. And again, it's a great pleasure and a privilege for me to introduce Professor Nalini M. Guda, who is the Director of Advanced Endoscopy Fellowship and GI Associates in Milwaukee. He is a clinical adjunct professor of medicine at the University of Wisconsin School of Medicine and Public Health, and a governor of the ACG for Wisconsin. After completing his training in India and residency in internal medicine and gastroenterology at the Aurora Sinai Medical Center in the University of Wisconsin, he has developed special interests in biliary pancreatic disease management and is actively involved in medical education and clinical research. Co-authored book chapters, reviews, and published original research in leading gastroenterology journals. With these few words, I think we can move on to now to the heart of the session for the evening, and hand over the mic to Professor Vivek Kaul. Professor Kaul, please.
Thank you, Dr. Saraswat and Dr. TSC fondly for having me as part of this very unique and very educational seminar. I think that I echo all the sentiments that Dr. Saraswat just mentioned, and it's unique to have an educational kind of approach to modern gastroenterology practice, because things tend to get lost in the world of endoscopy, and especially for the young trainees and for people who are young faculty and practitioners, it's important to keep up to date with what's happening, and a lot is happening on almost a weekly basis across the world. So I think this is great, and I particularly like the idea of converting this seminar at the end into a manuscript or into a book form, which will be enduring material. I can speak for myself and John. We're particularly excited that the collaboration with the Indian Society and ACG has gone forth in this manner, and I think we're trying to do that across many fora in the world, and the world is increasingly a smaller space. So with those words, I would like to introduce Professor Noria Oido. Great pleasure to have him here, and for me to introduce. He's Vice Director of the Department of Gastrointestinal Oncology at the Osaka International Cancer Institute. Huge investment in things GI cancer. He is really a renowned physician and endoscopist and researcher in the field of advanced endoscopic imaging. He serves as a counselor for multiple Japanese gastrointestinal societies, including the Japanese Cancer Society for GI cancer. He has been a visiting professor to the US, to Sweden, to China and other places, and serves as an associate editor for Digestive Endoscopy and several other journals. Today's topic for Dr. Oido is advanced endoscopic imaging, and there have been several landmark publications in the recent times, many of them with significant impact on endoscopic practice, especially in the realm of GI cancer. So it's a great topic, a topic that doesn't always receive a lot of attention at the national meetings, but this is a highly focused 15-20-minute talk that I had a sneak preview at. So thanks, Noria, for sending it over. And over to you, Dr. Oido. And thank you very much for doing this.
Thank you very much, Professor Vivek, for my kind introduction. And also thank you very much for Professor Chandra Shekhar for kind invitation. So I would start my talk for about the 10 most impactful publication of advanced endoscopic imaging. So I have no CLI disclosure. So initially in 2008, there is a gastroenterology publication which explain about the terminology of image enhanced endoscopy. Image enhanced endoscopy includes several various methods of enhancing endoscopic imaging, including dye-based image enhanced endoscopy and equipment-based image enhanced endoscopy. And after that, in 2016, European Society summarized such kind of technology. Probably, maybe it indicate equipment-based image enhanced endoscopy technology, push button technology to improve endoscopic image for enhancement. So it includes optical enhancement method and electronic enhancement method. So I would like to initially explain about the difference of optical image enhancement and electronic image enhancement. So optical image enhancement is like a use of optical filter to change illumination lights to narrow banded short wavelength light, which contrast mucosal surface structure and the mucosal superficial vasculature like this. And not only optical technology, usually image enhanced technology use electronic enhancement as well to change the color of the endoscopic image to contrast vessel color or surface mucosal color like this. So in another manufacturer also have such kind of image enhanced equipments. So this uses laser lights to produce different illumination lights. And then after that, they change the color according to some specific purpose like this. So it contrasts vessel as a brownish color, or sometimes it enhances the reddish color to more redder and a whitish color to more whitish to contrast the endoscopic mucosal lesions. So why such kind of advanced endoscopy image is necessary? For such kind of advanced lesion, advanced imaging is not necessary. However, the early stage lesion or even pre-malignant lesion, usually it is very difficult to identify only white light image because it has only subtle color change or morphological change. So what we do is usually we take random biopsy from unidentified lesion or target biopsy from identified lesion but uncertain lesion. However, image enhanced endoscopy improve identification of such kind of subtle mucosal changes. And also, if we use magnifying endoscopy, we can improve characterization of detected lesion. So we can perform early or immediate clinical decision making without biopsy. So that is the importance of advanced endoscopic imaging. So I would like to introduce some important publication for esophagus. So first important publication is the detection, usefulness of advanced endoscopic imaging for detection of superficial squamous cell carcinoma. In this multicenter randomized control trial, enrolling 300 patients, the patient was assigned to white light and NBI group, and then it showed that the NBI significantly improved detection of esophageal squamous cell carcinoma, and also squamous carcinoma in head and neck region. And also in this study, they also evaluate the characterization, whether it is squamous cell carcinoma or non-squamous cell carcinoma with endoscopic image, and it significantly improved diagnostic accuracy to differentiation, characterization of the detected lesion. Another important publication is recently usefulness of magnifying NBI to prediction of depth of esophageal squamous cell carcinoma is also reported. In this multicenter prospective cohort study, they show that the prediction depth is very accurate in terms of a vessel finding, such as loop or non-loop vessel or highly dilated vessel. And our colleague, Ryu Ishihara, conducted the meta-analysis, and he found that magnifying advanced diagnostic imaging can show almost similar diagnostic accuracy for prediction of depth compared to EUS, and shows a better diagnostic accuracy compared to non-magnifying advanced diagnostic imaging. And regarding to diagnosis of Barrett esophagus, there is one randomized control trial. So in this study, they compare the random biopsy and the white light image versus NBI-guided targeted biopsy for detection of intestinal metaplasia, meaning a Barrett esophagus. So what they found was the NBI detection rate of biopsy-proven intestinal metaplasia detection rate was the same compared to white light diagnosis random biopsy versus NBI targeted biopsy. However, the number of biopsy to prove intestinal metaplasia was significantly less in targeted NBI diagnosis compared to random biopsy in white light image. And also patient-wise detection rate did not reach to significant level. However, region-wise NBI detected significantly more lesion area with dysplasia or carcinoma compared to white light image. So NBI improve detection of dysplasia in a Barrett esophagus. So I'd like to explain about introduce some publication in the stomach. This is a single center retrospective observational study, but I want to include this publication into impactful publication. This was published by Dr. Ken Xiao when he visited a hospital in the United Kingdom. And reason why I choose this publication is that before this publication, we did not know how to interpret such kind of NBI magnification images, how to interpret such kind of finding. And also, we did not know usefulness of use of black soft food to achieve very good quality of images. So in this study, he classified or clarified the useful finding to useful endoscopic diagnostic criteria of magnifying NBI to make diagnosis of early gastric cancer. He clarified that the use of evaluation of irregular vessel or irregular microsurface structure with demarcation line has sensitivity of 90% for diagnosis of early gastric cancer. And after that, this usefulness of this diagnostic criteria was proven in a randomized control, multi-center randomized control trial. I also involved in this study, but in this study, we enroll 1,300 patients and then randomize into magnifying NB and screen the patient with white light image. And then if we detected some small depressed area, we randomize the lesion into magnifying NBI group and white light image group, and then evaluated diagnostic accuracy for characterization of detected lesion. So what we found was magnifying NBI significantly improved the characterization whether it is cancer or non-cancer for detected small depressed lesions. So NBI, magnifying NBI is useful for characterization. However, initially, NBI image was very dark, so it was regarded, it was thought that not useful, not suitable for detection of the lesion. However, after development of second generation bright NBI, we conducted the randomized control trial to investigate the detection of early gastric cancer by bright second generation NBI. So in this study, we enroll 4,500 patients and then randomized into two groups, and then evaluated the detection rate of patients with newly detected early gastric cancer between the two groups. So, but we found that although it improved the positive predictive value for diagnosis of the detected lesion, however, actual detection rate of patients with early gastric cancer, unfortunately, we could not prove significant advantage of NBI. And however, furthermore, we also investigated the diagnostic accuracy of near focus endoscope for characterization of detected lesion as a secondary primary and secondary endpoint in this randomized control trial. Near focus NBI, near focus endoscope is available outside Japan. So sometimes Japanese endoscopy can make good diagnosis because we have a optical zoom high magnification endoscope. And outside Japan, there is no high magnification endoscope. So that is the reason why it is very difficult to make diagnosis of early gastric cancer outside Japan. Sometimes it is said like that. However, in this secondary analysis, we found that the near-focus NEBI showed almost a similar diagnostic accuracy compared to high magnification zoom NBI. So I think even in India, if you learn and train your eyes or mind, maybe you can reproduce Japanese accuracy in your practice. So regarding to another type of advanced diagnostic imaging, it is investigated usefulness of linked color imaging for detection of early stage neoplasia in the upper GI tract. This study was recently published in Annals of Internal Medicine. In this study, they enroll 1,500 patients and then compare the proportion of patients with newly detected one or more neoplastic lesion in the upper GI tract. So they show that the linked color imaging improve detection of upper GI lesion, upper GI neoplasia compared to white light image, significantly improve detection of upper GI neoplasia, superficial neoplasia. Okay, at last, I want to introduce a publication in colorectal. So I think one of the most important study for advanced diagnostic imaging in the colorectal is the development of NICE classification. So in initial observational study, they invited a panel of international experts and then developed the useful NBI classification for characterization of colorectal polyps. So they classify the lesion according to color and surface and vasculature. And the preliminary validation shows the very good accuracy for differentiation of neoplasia, non-neoplastic polyp, and neoplastic polyps. However, in a multi-center prospective cohort study in Britain, they show that the study enrolling 1,600 patients, they evaluate clinically relevant outcome, such as patient with adenoma, detection rate of patient with adenoma, or detection rate of patient who need surveillance according to guideline. So they found that the diagnostic accuracy of NICE classification was not as good as they expected. So in conclusion, they conclude that maybe so far currently use of probably advanced diagnostic imaging could not replace actual histological biopsy diagnosis so far. And probably this is also true. Sometimes we misunderstand that technology can solve all the problem, but still we have to learn some knowledge and we have to learn some skill. So probably this is a real situation. Or maybe in the future, artificial intelligence or AI technology can compensate such kind of learning curve. So this is a last publication. So this is a last usefulness of NBI for detection of colorectal neoplasia using meta-analysis of 11 randomized control trial. They found that NBI significantly improved detection of adenoma, colorectal adenoma. And interestingly, they also show that under good bowel prep, usefulness of advanced diagnostic imaging is obvious. So it means, as I explained, sometimes some people think that technology can solve all the problem, but still basic preparation, basic things is still important to achieve good outcome. So anyway, and I introduced many clinical relevant publication is available for usefulness of advanced endoscopy imaging for identification and characterization of mucosal abnormality of GI tract. So this is a recently published Japanese guideline. So it stated that image enhanced endoscopy is useful for diagnosis of early gastric cancer. However, level of evidence is strong, but a recommendation was weak. So the reason why the weak recommendation was because this technique is still limited, only feasible in limited institutions, even though it has a very strong evidence. And I want to introduce some new technology, new launched machines. So this is compatible with 100 series endoscopy available in India and also 200 series endoscope in Japan. So it has some color enhancement technology similar to linked color imaging. So it is expected to improve detection of the lesion. And also a new scope has a expanded depth function. So usually optical zoom scope, we can see only close near a good focus in a near area. However, new scope has a wide depth, good focus area like this. So I want to show one video. So you can see some whitish lesion like this. So color of the lesion is enhanced by electronical enhancement like this. So this time I used optical zoom scope. Maybe you may see vasculature, but the image is a bit unstable like this. And also I used very fine movement of scope handling and also very fine movement of left thumb control of the magnifying lever. However, new expanded depth of field endoscope can just press the button. So we can achieve very stable, very panoramic, good focus images of the vasculature like this. So this kind of scope or technology facilitate use of this kind of advanced diagnostic imaging in routine clinical practice. So probably further new technology and maybe combination of AI will increase dissemination of advanced diagnostic imaging and benefit patient care in the future. Thank you very much for kind attention.
I must thank you, Professor Oido, for a fantastic presentation and a mind-opening exposure to which way the new technology is going and how it's going to have an impact on our diagnostic capabilities in the future. I think we do have a lot of questions and clarifications, but as has been decided in the format for this meeting, we'll take them up in the question and answer session after the second talk is presented.
Okay.
So with this, thank you once again for a lovely presentation.
Thank you.
I'll now request Professor Nalini Guda to please introduce the next speaker, and we move ahead with the session. Thank you.
Good evening, everyone, and good morning from Milwaukee, Wisconsin. It's my great honor and pleasure to introduce Dr. Salzman. I think 3 years back, we were in Minneapolis in person. Now the world has changed. We are virtually connected. Dr. Salzman needs no introduction, but I still would spend a minute trying to explain his achievements over the last few years. He's currently professor of medicine at Harvard Medical School. He's a senior physician, Division of Gastroenterology, Hepatology, and Nutrition. And he's also a trustee of the ACG Board of Trustees and liaison for Educational Affairs. So he's even more thrilled to be here because this is an ACG endorsed event. He has authored more than 300 articles, including original research, reviews, and chapters. He's a very well sought after speaker. He's an expert in bleeds, and we often send him questions about managing bleeding issues in patients on anticoagulations and post-procedural issues. He's an expert in endoscopy, imaging, and GI bleeding. And he's a senior associate editor for gastrointestinal endoscopy. He's the section editor for diagnostic and therapeutic endoscopy for UpToDate. And he also is the associate editor for Journal Watch Gastroenterology. And as some of you might be seeing a microscope right next to his right hand, John also was apparently a career hepatologist before he turned into endoscopy and therapeutic endoscopy. So that is a real functional microscope next to him. So without much further ado, I would like to hand over to Dr. Salzman for reviewing the literature on GI bleed, how we have come this far, and what do we do in the future.
Well, thank you for that lovely introduction, Nalini. I'm really appreciative to be here today and to participate in this conference. Thank you, Dr. Chandra Shekhar, for inviting me to participate in this webinar. It's been a pleasure to get to know you first when I was visiting India, and we got to be together. And then when you came to the United States and received the Community Service and Outstanding Humanitarian Award from the American College of Gastroenterology. So congratulations again on that, and thank you for inviting me today to participate. So let me bring up my slides here. So I also have to congratulate you for coming up with this idea of the most impactful publications in different areas. It's really important for us to understand what we're doing today by understanding where we were, and then we can have a context about where we're going to be. And what I've tried to do here is present some of what I think are the pivotal landmark changing articles in the field that have formulated what we do today. And as you know, most research is iterative. We build little steps on the shoulders of the next person. But every now and then there are these landmark publications that change what we do. And so I'm going to present to you some of the landmark publications, not all, but some of them that I think are particularly interesting. And I've decided to approach this by chronological order. So it starts back in 1974 with this publication in Lancet, which was a correspondence basically by John Forrest. And it's his retrospective experience of about 110 endoscopies. And what can you get out of this experience in the early 70s? Well, there's actually a lot that you can get out of this. It's really very impressive what he was able to do. First, he looked at from time of admission to endoscopy, so timing of endoscopy. And at this stage, it was diagnosis, not therapy they were interested in. And so what we look at is success rate of diagnosis. And if you did an endoscopy within 24 hours, you're about 80% successful at locating the bleeding site. If you did it within 48 hours, you're at 66% successful. So even in this early stage, you can start to see where we start to get these within 24-hour doing an endoscopy recommendations. And then he went on to develop what became what was called the Forrest classification. And what he did was characterize the lesions that he saw. Again, this is 100 patients in his experience, and he characterized them into three groups: actively bleeding lesions, recently bleeding lesions, and non-bleeding lesions. So now this is the start of the construct of how we think about what we're looking at. And this was the first attempt to do this. And as such, it's really a landmark change in how we approach GI bleeding. What's happened to this is that there have been many publications, and I believe James Lau changed it to the modified Forest classification and the stigmata of recent hemorrhage. And now we talk about Forest class 1A and 1B lesions, which are the actively bleeding, 1A spurting, 1B oozing lesions. The Forest 2A lesions, the non-bleeding visible vessels, 2B adherent clots, 2C pigmented spots, and ulcer base. And if you look at this, it predicts outcome. And the main things these days we're looking at is rates of further bleeding and mortality. The surgery rates have changed as our therapies and other things have changed, but the main categories of active bleeding, non-bleeding visible vessels associated with high rates of further bleeding, non-bleeding visible vessels about 50% if no further action is done, and significant mortality, adherent clots about 20% of further bleeding. And that has now guided our decisions on who do we do endoscopic therapy. So now it's routinely recommended if you see active bleeding, you treat. If you see a non-bleeding visible vessel, even though it's not bleeding, has a very high risk of further bleeding if you don't treat, and you need to treat. Adherent clots are controversial, but it really depends on what's underneath that clot. And maybe we can discuss this at the question and answer stage. And then flat spots and clean ulcers you don't need to treat. All right, 1987. This is, to me, the my favorite article in all of gastroenterology. And it's my favorite article in all of GI bleeding. And that's because this is Lauren Lane's study of multipolar electrocoagulation BiCAP therapy to treat active GI hemorrhage, a prospective randomized controlled trial. Why is it my favorite? One, it's a single authored study, randomized controlled trial in the New England Journal of Medicine. I don't think I've ever seen another prospective randomized controlled trial as a single author. And I love how he writes, I performed a prospective controlled trial, I conclude that. And this changed our therapy, a view of endoscopy from a diagnostic modality to a therapeutic modality. Let me show you what he found. What Lauren did, and I should further emphasize what Lauren did this a couple of years after his GI fellowship. He was a new attending within a couple of years of finishing his attending, being a fellow, and he's at a VA hospital, and all by himself, he does this study where he randomized patients to sham therapy, so he does an endoscopy, doesn't do therapy, or multipolar electrocoagulation. And he looks at what happened, and basically there were significantly fewer transfusions if you were treated with BiCAP, hemostasis rates were better, less emergency interventions, shorter hospital stays, and lower costs. So in 1987, endoscopic therapy became standard of care based on this one landmark paper. And these were significant. Nowadays, we have all these different therapies, and I just listed our standard therapies now: injection methods, thermal methods, mechanical, clips, in combination, usually epi plus clips. And all these are improvements on it and are very important on their own. But I think that that initial publication was, half of the story are endoscopy therapy. Well, here's the other half of the story that came up, which is my second favorite publication in GI. And this is a publication from Kuru et al. That came out of Kashmir. And they were looking at the value of omeprazole versus placebo in peptic ulcers. And you have to look at the design of their study very closely. And that what they gave is high dose PPIs, omeprazole 40 orally twice a day, and 220 patients with ulcers, but they scoped these patients and they found high-risk stigmata, active bleeding, non-bleeding visible vessels, and adherent clots. So they then measured what happened if they were randomized to the omeprazole or not. And unlike the standard of care that Lauren Lane had introduced, there was no endoscopic therapy done in these patients. And the reason why there's no endoscopic therapy done is that this was done in Kashmir, and Kuru was the only endoscopist who knew how to do endoscopic therapy and was felt to be ethically justifiable at the time. So we got to see the effects of omeprazole alone in a select group. And this is what they found. If you were actively bleeding, spurting or oozing, the 1A, 1Bs, there was no impact of omeprazole. However, if you had a visible vessel, your rates of further bleeding went from 50%, which was as we expected, down to 10%. And if you had an hair clot, they went from about 20%, at least in this study, down to 0%. So a definite impact in patients who did not receive endoscopic therapy. Well, hugely impactful. The other reason why this is my second favorite paper is at the time I was a junior attending at the University of Massachusetts and running the endoscopy, the GI bleeding service for the hospital. And I was asked to write the editorial for the New England Journal article by Kuro et al. And what I concluded is basically that further controlled trials were needed to clarify the benefit of these medications in patients who receive standard of care or endoscopic therapy. So I thought it was premature to recommend this, but we needed a trial of endoscopic therapy combined with PPIs to know the added value. So this was 1997. We didn't have to wait long. In 2000, this paper came out, and this is the group that I consider the best group in the world in terms of their management of GI bleeding from Hong Kong. And you'll see these names over and over and over again in the studies. James Lau, Joseph Sung, Francis Chan. They had incredible contributions, and they did the study. And what did they do? They found patients who needed endoscopic treatment, and they treated with combination therapy. They successfully treated them, and then they randomized them after treatment to omeprazole 80 milligrams bolus followed by an infusion versus a placebo infusion. So that's the design of the trial. And what they found is that with the PPIs, there was less rebleeding, so which was quite significant, and less rebleeding within 3 days. The rates of surgery and death were not significantly different, although they looked like they would be improved if the study had been large enough, but they weren't significant. So with this study, now we know that it's not just endoscopy, but it's endoscopy plus PPIs. So these are the foundations of what we do now, endoscopy and medical therapy. And this has resulted in guidelines, and these are the guidelines from Alan Barkin, which is an international group that he's headed. And he said, for patients with bleeding ulcers with high-risk stigmata of undergoing successful endoscopic therapy, we recommend using PPI therapy via an IV loading dose, followed by continuous infusion IV. And then I just put as a note here, we don't know whether to start PPIs before endoscopy, as there's one randomized trial, also done by the same group, showed a decrease in stigmata of recent hemorrhage, but no change in clinical outcomes. And then importantly, they've added within 3 days of an IV PPI, change it to twice a day oral PPI through 14 days, followed by once daily, decrease costs, decrease potential side effects from medication. So the next article that I chose is this article by Oliver Blatchford and all. And what this is the development of a risk prognostic score in GI bleeding. This is not the first prognostic score. There have been several before here, including the Rockhall, which is well known. But what they did is looked at factors only present in the emergency department. So this is pre-endoscopy, and this is real world when we need to make our decisions. And this is what they came up with, a score that assessed the need for intervention, the need for transfusion, endoscopic intervention, surgery, or IR. It sets 8 categories with a score of 0 to 23. It's easy to calculate, although it's easy to put into a risk calculator, which are available online or an up-to-date. It's best validated actually to predict low risk. If you're a 0 to 1, you have about a 99% chance that you're not going to need any intervention at all. And it also has been widely used to predict high risk, particularly those who are over 12 are at the highest risk, but probably starting around 7, you're at high risk with a Blatchford score. So I think this is a landmark article. It's allowed us to add risk stratification and that we can predict low risk, of which I think the Blatchford is the best score currently, or high risk. And it's either the Blatchford or the score that I came up with, which is the AIM-65 score, which is also another pre-endoscopy score, which can allow us to figure out who should be treating the ICU, who might need urgent interventions, so we can decrease rebleeding and mortality. And this has been recommended by all the guidelines that are out there, the International Consensus Guidelines and the American College of Gastroenterology guidelines. Another important issue that has come up in recent years is the issue of antithrombotics. We are seeing more and more patients come in who are bleeding, who are on medications. We used to think that ulcers were all due to H. pylori, and if they weren't H. pylori, it was NSAIDs. And this was true 30 years ago, but it's changed dramatically. And that H. pylori, at least in the United States, is responsible for probably 20% of ulcers. And the majority are related to medications. And medications are a major problem. And the problem is with these medications that affect platelet function and coagulation is that if you keep them on, they'll keep bleeding, but you want to avoid the thromboembolic events. So we're always in this paradox where we're trying to avoid rebleeding, but we also don't want patients to have a thromboembolic event, a stroke or an MI, and those actually are the more important and serious events. So how do we manage this? Well, again, the Hong Kong group, this trial first author was Cho So-sung, looked at this with aspirin and peptic ulcer disease. And they did a beautiful trial where they took patients who were on aspirin for secondary prevention. They already had a cardiac event. And they randomized them when they came in with a bleeding ulcer to continue on their aspirin after they stopped their bleeding or to withhold their aspirin for a month and see what happened. And this is what happened in terms of bleeding. If they continued on aspirin compared to placebo, they had twice the amount of bleeding. So this is bad. And that's the reason why we gastroenterologists want to help hold the aspirin. On the other hand, if you look on the right side of this, they had, if you continued aspirin, you had 1/9 the mortality in 30 days than if you went on placebo. So patients who need to be on these antithrombotic drugs for secondary prevention, they're going to develop events within 30 days, and you need to get them back on their medications. So it's critical to get patients back on their antithrombotics as soon as their bleeding stabilizes. So I just have one slide here that I'll tell you what's my overview of the state of the art for antithrombotics is that you manage with IV hydration, supportive measures in general, and then you, oops, sorry about that. Go back. Yeah, here we are. Then you withhold the drugs in consultation with cardiology, usually, or prescribing medications. Endoscopic therapy is safe and effective when the INR is less than 2.5, so you don't have to wait till it's normalized, and we can talk about this more if you want in the questions to answer. There are reversal agents for the anticoagulants, although most patients don't need this. You can reverse anticoagulation with warfarin, with prothrombin complex concentrates. These are the most effective agents, or FFP or vitamin K. And the DOACs, the direct oral anticoagulants, they're now reversal agents. And it's important to restart these medications when the bleeding stabilizes. All right, now I'm going to move on to some other concepts. This is my only trial I'm going to show you, which is an animal study. And this was a study done of a hemostatic spray, TC325. TC325 is an agent that was developed in the military to stop bleeding in the field. The idea was to pack a wound, such as after a gunshot or an explosive in the iliac artery, with this powder to get it to stop bleeding enough that you could get the person to a hospital to have definitive therapy. And this is a study from Johns Hopkins University where they took a anticoagulated animal model. They cut the one of the large gastric arteries, the left gastric artery, in an anticoagulated model, and then they sprayed spray on this, and they could show that it could stop bleeding effectively. Really, this is a disruptive technology that changes how we think about how we can control bleeding. And since this original study now almost 10 years ago, there have been many, many studies, mainly cohort studies that have been looked at this initially with the Hong Kong group, but now throughout the world. And I just want us to summarize where we are with this. So I like hemostatic sprays a lot. They don't require special expertise. You don't have to have special equipment. You just have to get to the area of the bleeding and press a button to spray on. It may be effective in difficult locations where our traditional therapies, such as clipping, are difficult to employ. You can rapidly use this after an endoscopic therapy. If you're in the middle of a removal of a large lesion or sphincterotomy, develop bleeding, you can treat. And this has a definite role in malignant bleeding. So patients who are bleeding from malignancy, we have very few other options, and hemostatic spray seems to work. It only works in the actively oozing or spurting lesions. It's not helpful for a non-bleeding visible vessel. And we're learning that a second treatment modality is needed if there's a high risk of rebleeding. So lesions that come in that are spurting, very big arteries, I would apply a second type of modality to prevent further bleeding. And there's a possible role in variceal bleeding. All right, so this is another concept that was a disruptive concept in our management. What are the right transfusion thresholds to manage patients who come in with GI bleeding? I was taught, and up until the time of this paper, I gave, as part of my care, transfusion for a hemoglobin target of 9 or 10 grams per deciliter. And what Villanueva did, and this is a study from Spain, is that they randomized patients who came in with a GI bleed to a liberal strategy, which is our traditional strategy, thresholds of 9 or 10, or a restrictive strategy of a 7-gram target. And it was felt that too much blood could be a bad thing for a variety of reasons. And so you can see what happened to mortality, and it was significantly better in those with the restrictive strategy, the 7-gram per deciliter group. And this is sort of the subgroup analysis. Overall, the hazard ratio very significant for a restrictive strategy. And although my talk today is not about variceal bleeding, the benefit was highest in child's A and B varices. It's felt that in variceal bleeding, if you add too much blood, you basically fill up the system, you pop off that clot that's forming, and you start bleeding again. So this has become our standard of care, and it's been incorporated in these guidelines, such as the ACG guidelines, where the concepts of the management is you assess the hemodynamic status, you get in 2 large bore 16 or 18 gauge IVs, you start resuscitating, and then you use these transfusion targets of 7 grams. And you only have a higher threshold if there's such, massive bleeding that you're not sure of their vascular status, or if they have active acute coronary syndrome or active coronary disease. And then this is a study I think is worth mentioning. This is my only non-original investigation. It's a guideline. And guidelines are very important to help us understand a changing world and literature. And it's hard to write guidelines, and it's hard to do it across countries. And Alan Barkin should be commended for putting together, and this is the 3rd time he's done this, an international group of people who have written guidelines, and this was released last year. And as you look at these guidelines, you'll recognize, in addition to Alan, Lauren Lane, Joseph Sung, Francis Chan, other major leaders in this field, Ian Gralnick, Dane Jensen, James Lau. And I had the pleasure, I think we were seated alphabetically at this, of sitting next to Nagi Reddy, and I was on this panel as well. But I think these are really important to pay attention to the guidelines and how they synthesize the information that's out there. And Alan and Lauren and Gregorius and myself have rewritten the guidelines for the American College of Gastroenterology and submitted them for review and publications. So you should see new guidelines from the American College in the coming year. So the last issue I wanted to talk about was timing of endoscopy. I started at the beginning with the study by Forrest that showed you should do endoscopy with 24 hours, and not only for diagnosis, but for therapy, and that's what the guidelines say. And furthermore, some guidelines, including the European guidelines, say, well, perhaps you should do it earlier, within 12 hours in patients who are particularly high risk, hemodynamic instability, bloody emesis, those are on antithrombotics. But it's possible that worse outcomes may occur. And this may be due to inadequate resuscitation of patients. It may be done without your usual supports. And maybe your and performance is not good at off hours. And this is probably true for all of endoscopy, but if you're doing emergency endoscopy in the middle of the night, your performance may not be as good as it is during the day. And if you provoke bleeding, your backups may not be immediately available. I've been interested in this, and this is a publication by Larsen from Denmark, and this is a publication from my hospital that came out with identical results. But basically, if you look at from time of presentation mortality, and this is by ASA classification here, hemodynamically stable but with high ASA risk. If you go in too early, your mortality is increase, and if you go late, your mortality is increased. And your sweet spot is not at the very beginning, but somewhere in the 10 to 24 hour range. So it may be this is retrospective data that too early is not good. And we didn't have to wait too long to get the answer. We all knew that the Chinese Hong Kong group was working on this, and they published just this year in April a landmark study about timing. And what they did is they randomized patients who came in with upper GI bleeding. They had high Blatchford scores. Remember what we talked about, Blatchford, over 12 or more. And they had randomized to early endoscopy within 6-hour presentation, or their standard within 24 hours of presentation. And you see that they look at deaths and further bleeding. And overall, there's no significant difference between the two groups. However, if you look closely, the rates of death and further bleeding are higher in the urgent endoscopy group. So although they can't tell that for sure, there's no benefit that we can say from early endoscopy, and there may be increased risk by doing it too early, mainly from the under-resuscitation. So my take-home points are, I think you should risk stratify your patients when they come in with GI bleeding. Blatchford is the best known one, and that's what I would use. And you don't just risk stratify alone, you compare this to your clinical judgment and see if it's congruent, and if it's different, then you should be thinking about, well, what's going on here. Transfusion, packed red blood cells, you should be using targets of 7 unless you have a significant acute coronary syndrome or massive bleeding. Perform our endoscopies within 24 hours, that is the goal, and only selectively should you do it earlier and I mean emergently within a couple of hours, but first resuscitate your patients. You should do endoscopic therapy in those forest 1A, 1B, and 2A lesions, as we spoke, because of their risk of further bleeding and death and mortality if you don't. I would treat with a high dose PPI if endoscopic therapy is done, typically for 72 hours in the hospital before switching to an oral PPI. Hemostatic sprays are a very useful adjunct now. We can use to treat active bleeding. We can use for rescue bleeding that are not responsive to other modalities. And I think it's part of our armamentarium now. It's very important that we're seeing more and more patients who are on antithrombotics. Restart the antithrombotics when you think the bleeding risk has decreased to an acceptable point. And be aware of that this field is a changing field. I've showed you a lot of studies, including some from this year, and there are new guidelines and new coming out, and this should be our foundation of how we manage and treat our patients. So thank you again for allowing me to participate today in this wonderful webinar, and I look forward to the question and answer period.
Well, thank you very much, Professor Salzman. I think we've thoroughly enjoyed the journey that you have taken us through the landmark publications in the area of non-variceal upper GI hemorrhage. And I'm actually wondering whether 10 landmark papers is enough, or you actually have many more landmarks on the way.
Yeah, that is a major problem, is only picking 10 is really excluding a lot of landmark work that's been done by many deserving other publications.
Dr. Saraswat, I agree with you. There will be a lot of papers will be there. The idea why I generated this concept of 10 landmarks, there somewhere we have to fix the, see, some people say endoscopy in 24 hours. Why not 48 hours and 6 hours, all these things. These 10 landmark papers should not be forgotten, should be recalled, should be recollected, and should be retold, and should be applied. So I made it like that 10. So, I know John may not like me because he wanted to tell 30 landmark papers. So he made it 10. It's a tough job.
What you could do is when we have these chapters in your book that we are all looking forward to so much. There'll be
Okay.
10 landmarks like the Empire State Building and the Qutub Minar, but there can be 30 milestones on the way to the landmarks.
Okay.
Yeah.
Right. And I
Get
have a
some
great
targets.
pleasure in inviting all the things of the dais for the panel discussion. Apart from Professor Saraswat already there, Dr. John, Dr. Nalini, and Dr. Udo, and Dr. Gokul, and Vivek, and everyone. And the burning questions, some of the questions are going to be from Dr. Saraswat, some from Gokul. Already I have 124 questions are there. The first question is surprisingly to Vivek Kaul and to Dr. Nalini. In USA, what is the concept of endoscopy advanced imaging? Do you do it yourself, or there is a specialist available to do the advanced endoscopy imaging? If you are doing, how do you spare time for this?
Nalini, you want to take that on? Sure.
And then I'll chime in.
I think compared to the East, in terms of endoscopy imaging, we currently employ, narrowband imaging, or depending on the model of the scope you use, the alternate electronic versions of changing the light and viewing it. We do not have any person who is separate from the endoscopist who performs these procedures. Regarding the time, I think people who are, more conscientious about it, they spend a few more minutes looking at it. With the new scopes that are available, most of them do come in with either NBI or FICE or whatever the brand of scopes you use. So those are available in most even outpatient endoscopy centers where most of the endoscopies are performed.
A small panel. I want you to be very brief to the point because we can take up more questions. So Nalini says he's going to try one youngsters for the endoscopy imaging. What about Vivek Kaul?
Yeah, I think the issues that were raised in the question are very pertinent. Time is of the essence in American endoscopy. Reimbursement is another issue. Unlike the Japanese colleagues, we have a different paradigm for the practice of endoscopy, especially on the private practice side, but equally so on the academic side. So it's difficult to incorporate that. Having said that, we've had multiple platforms for advanced imaging in place over the last decade, and I think it started with the endomicroscopy, with the confocal laser endomicroscopy system, and then subsequently the optical coherence tomography, especially in Barrett's, which is now volumetric laser endomicroscopy. So these are systems that are prevalent in about, I would say, 60 to 100 institutions in the country. There have been some multi-center trials on those as well.
My question is very pointed, Vivek. You should have a general endoscopist, or you need to have a specialist endoscopist, because we need to allot like that, because that's the reason I was asking you.
Right. So the answer is that yes, ideally it should be a specialization, but right now it's most everybody is using it in a variable way. There's no degree of specialization in this country. I don't believe it.
Now I want to ask our president of Indian Society.
The small point now I'd like to make is that this area, it is how do we see foresee the future as we move along? The optimum amount of time to be spent in screening a person considered to be at risk for early gastric cancer, how much would it be? And would it not be better to move to a specialized breed of endoscopists who concentrate on this area? Because generally pressing a button and you'll do a screening job. You may not do a thorough job, which would be the purpose. So how do we have the best experts here? How do they see the future here evolving? And do they find a time that they may be need for a specialist? A very pertinent question that TSC brought first up.
Vivek, you are being the president. What should be our idea? Should we train all our youngsters in advanced endoscopy imaging in a unit so that we will be well versed?
I think my counterpart, Dr. Vivek Kaul, hit the nail on the head. If you guys pay them enough and so that they can spend their time only doing diagnostic endoscopy and not do the glamour bits, the interventional endoscopy, bariatric surgery, third space and all, then you may get people to pick this area up. Otherwise, people will tend to go where the glamour is, and where eventually I think the returns are better, rather than simply being stuck with what will be seen as the non-interventional work diagnostic.
Okay. Same
So
question pointed to the, Dr. John Salzman and Dr. Udo. What is your concept? But you want a specialist, advanced endoscopy imaging specialist, or you want to be trained? And how do you then? What do you think, Professor?
future.
Finally, the Japanese concept.
So actually, probably for detection, I think it should be more global, generalized. So I think advanced image should not be really specialized. I think it's really depend on the training or learning. So even though simple clipping or polypectomy, we learn something. And advanced imaging diagnosis much easier. So if they learn appropriately under the training, so I think it really improve. So similar to other conventional endoscopy diagnosis. So screening or detection should be generalized more, not so specific.
Okay. The question is to use the Professor Udo.
Yes.
How long you want to train somebody in this advanced endoscopy imaging? Because there is a doctor we asked from Dehradun, how long do I need? Can I come and get trained by you? From
So
you?
maybe that is also, it depends on the different situation. For example, in Japan, we have a lot of conferences or experts around around areas. Once my one young Taiwanese doctor visited our hospital, and he was really interested in diagnosis with advanced diagnostic imaging. But after he came back to Taiwan, nobody can teach him. So
okay, if I come to Japan, how long I need to take?
I think
Now, first of all, do you take me?
I think
Or you want very young people, very young people?
1 week or 2 weeks is enough.
2 weeks.
Yeah,
So let me
because
ask
we can
doctor, the
we can
youngest,
provide many informations. Yeah.
the youngest of the panel is Dr. Gokul. If you are given a choice, would you like to get trained?
Yes, sir. Basically, I'm interested in third space endoscopy. So picking up early GI cancers is very important. So I would be interested in learning early detection and characterization of tumors so that I can subject them to endoscopic resection like EMR or ESD.
So the answers from Nalini is, it may be specialized endoscopy may be better. And Dr. Saraswat says it depends on the need-based. You just don't want to trade. What is the future going to be? And Vivek Kaul says if you are doing a specialist job, we like to have a thing. And Dr. Wood said 2 weeks of endoscopy training would be better. Dr. John, would you be interested in advanced endoscopy imaging?
Well, I'm fascinated by advanced endoscopy imaging. I would say, though, in the United States, we've learned the biggest advance was high definition scopes. All of a sudden, we were seeing things that we never saw before. And then what MBI did for everyone is it made us see what we can see in high definition scopes without MBI for the most part. But our eyes were not trained. Like the Japanese are very trained to look at things. We didn't see it. So now you can usually see things with good high definition. But the main issue, and this goes against our compensation plan, is you have to slow down to look well. So I think for upper screening and for colon screening, you have to spend the right amount of time and you have to know what you're looking for. And what I think is the combination of time, quality scopes, and artificial intelligence is where we're going to go in the future.
Yeah.
Doctor from Australia is asking, Rajesh, sir, I'm an endoscopist. When do you advise all patients for endoscopy imaging, or is there any indicators you see in white light endoscopy, then you go for endoscopy advanced imaging, or any clinical criteria use it for advanced endoscopy imaging? As Dr. Vivek also said, that it is time consuming. So for all patients start doing advanced endoscopy imaging, what is your take, Professor Udo?
So I think selection of high risk patient is very important. If we perform, such kind of advanced things for general very low risk population, it's a kind of bit wasting. But initially it is very important to select a high risk patient, but after that, for detection, as I show, some randomized control trial already show that the advanced imaging detect more lesion compared to white light imaging. So if we select high risk patient, I think advanced imaging can detect more lesion. So initially it takes time. It took time, but after you learning, everything is the same. Initially, beginner always spend long time for the conventional endoscope, but once a while, they improve. So I think the same thing.
I think
Dr. Saraswat.
a very basic question that I'd request Professor Oido to address is what is the equipment? I mean, which are the endoscopes and models outside of Japan, which can be useful? What is the level of magnification? And the second would be that most of the data we see about the types, the pit patterns, and the endoscopic appearances are based on NBI and with Olympus scopes. Would they apply equally well to FICE and iScan from Pentax and Fujinon scopes? Is the literature is going to be exactly equivalent, or we need a different set of data and literature to validate the pictures from other systems other than Olympus NBI?
So as I explained, for detection of esophagus, squamous cell carcinoma in esophagus, NBI and BLI, recent Fuji system shows almost a similar detection and characterization. And FICE or iScan, there is no evidence to improve detection and characterization, especially large-scale study. So maybe NBI, BLI, and recently linked color imaging can detect more lesion. So I think three imaging technology was evidence proven, I think. And for magnification, as I mentioned, that even near focus scope, which we used in practice, almost a similar diagnostic accuracy to high magnification endoscope. So I think it can be reproducible if you train appropriately.
And you mentioned briefly about artificial imaging intelligence
Yes.
and how it is going to change image enhanced endoscopy. So could you elaborate on that a bit more? I mean, where are we? Is there some preliminary work happening, and how has AI impacted this area?
I think a good point of AI is improvement of learning curve. And I think it does not really improve. I mean that it does not change white light endoscopy accuracy to image enhanced level. So it can produce the high best performance of that method. So if we change imaging modality from white light to NBI, it improves accuracy. And the AI help learning. AI cannot improve white light diagnosis more than image enhanced technology. So I think AI help learning, but still basic improvement of diagnostic technology is still important. This is my idea.
And Dr. Google.
Sir, there is one question from Dr. Prasad from Hyderabad. Question to Professor Udo. So, with the advent of electronic chromoendoscopy like NBI, what is the role for conventional dye-based chromoendoscopy? That's a question.
So that is also a good point. We recently compared the conducted randomized control trial chromoendoscopy versus electronic image enhanced system. So we found the difference. We could not show the difference. So probably each dye-based image enhanced technology and the equipment-based technology has almost a similar diagnostic accuracy. But the equipment-based technology can achieve such kind of enhanced effect with just pressing the button. But we are not necessary to prepare dye or something. But in other words, even you don't have a new latest endoscopy system, if you use chromo dye, maybe you can improve diagnostic accuracy compared to white light image. So that is a different method, but we can achieve the almost similar improvement.
Professor Oido, there is a very interesting question to you. Diffuse type of the malignancy of gastric cancer, mostly we go for surgical treatment. But intestinal type of malignancy of stomach and endotherapy is also possible. Now we are claiming optical biopsy is going to take over histopathology. Is there anywhere advanced endoscopy imaging can differentiate intestinal type versus diffuse type?
I think there is one observational study that it has almost the diagnostic accuracy of 80% for differentiation of different histological type.
Can differentiate intestinal from diffuse type?
Diffuse type, yes.
And
They have
there are some markers.
because the intestinal type has a gland structure, but diffuse type does not create a gland structure. So vasculature or surface structure is different. So we can differentiate with 80% of sensitive diagnostic accuracy.
Any comment from Vivek Kaul and Nalini and questions before we take up other
Fantastic questions. In fact, I had the same list of questions I had from Nuria's talk, and the training protocol, the time, every case, some cases, but I think, at the end of the day, and I'm sure there's a lot of questions, I think from an American perspective, and I suppose from anywhere outside the Japan perspective, I think it's going to end up being, the easy availability of, reliable, reproducible technology that is relatively idiot-proof and has a high impact on patient care, diagnostic or therapeutic. That's the way I look at it. And I think that's where AI is going to potentially help, jumpstart this area, which has been kind of under the radar a little bit, focused in highly specialized centers, which is why Dr. Oido pointed out that it's very rare to have level A evidence in endoscopy. Very rare to have that. We generally have weak evidence. And then it's even more rare to have a weak recommendation in conjunct with the level A evidence. So that's the reason, is because it's such a niche area. It needs to be unniched, and that's what we're waiting for. But impact on patient care is the maximum, most important bullet point for me. And that's why in the realm of Barrett's, at least in our practices, it has proven to be much more useful than in colorectal neoplasia.
Dr. Nalini?
The great comments, great discussion. I think I agree with Dr. Oido that unless the general endoscopist recognizes that there is something wrong, you cannot send them to a specialist. So I think the future is that everybody should be trained to see these things, right? What your mind does not know, your eyes do not see. So we all need to know what to look at, spend time, as John said, look at it carefully. And if you find something wrong, then we can refer to more specialists to see whether that needs intervention or not. I have a couple of questions for John, if we switch gears. It was an excellent talk, John. I have two questions because they come up every day. Inpatient hospitalization costs money. We are in constant need to discharge patients early. Now, all these trials have used either a single modality or dual modality treatment, and these are all before mechanical hemostasis. Now we are putting hemoclips, controlling bleed much better. Do you still believe that we should keep the patients in-house for 72 hours on a PPI drip, or do you think we should start thinking about discharging sooner?
Yeah, it's a good question, and so what the premise of your question is that our endoscopic therapies are more effective now than they used to be, and I don't think that's true. I think that there is good data about thermocoagulation being effective, about epi along with thermocoagulation or clips being effective, but they're not better than they used to be. The only therapy that we've done that's come out in recent years that may be more durably effective is over-the-scope clips. So over the scope clips are these big clamps, and I didn't get to discuss that. It might be in my top 20 list, but it's a clamp-like clip that will go over a large vessel. And once you get that vessel, I think you're probably done with it. But if you're treating a non-bleeding visible vessel, you're treating a spurting vessel, those need to stay in for 3 days. If you're treating a little oozing bleeding, I don't know what oozing even is, because the way that the trials were done is oozing lesions were those that when you first look down are oozing and you watch for 5 minutes and they were still oozing. And every now and then we see just a little trickle of blood and we treat it and we think that's an oozing lesion, and it may not be anything really all that significant. So oozing lesions, I think you do have a little bit of options not to treat. I'll tell you, at least in the US, I have been an expert for lawsuits of people being discharged before 72 hours who then died on day 3 as an outpatient. So, and I just say, those are the guidelines, they should have followed them.
Second question relates to H. pylori, right? So
yeah.
There is so much antibiotic resistance. Do you routinely retest and retreat?
Yeah, so H. pylori, and the story may be different in India and Japan than the US, so I'm not sure of all the differences. But H. pylori, you should test for it in anyone who's bleeding. I think you should test for it in anyone who's going on long-term antithrombotics as well. And you should eradicate it by whatever you think is the best regimen. Generally, we're avoiding clarithromycin-based regimens because people are getting these drugs for all sorts of URIs and other things. But treating with another regimen. And if you treat, you must document eradication. In the past, we only said it had to be high-risk people. We're now realizing both for ulcers and for gastric cancers that if you don't get rid of that H. pylori, your risk is increased of having it in the follow-up period. So you must document, get rid of it. I typically do a breath test, 2 or 3 months later.
Professor John, there's a very basic question. We know that crystalloids are better than colloid. Any situation you want to give a combination of crystalloid and colloid?
Yeah, so this is a simple question.
What is the concept? What is your recommendation on this?
Yeah, so this is a simple question, but we don't have any high-level answers in GI. Any resuscitation literature is based on emergency literature from other traumatic diseases. So I actually, my solution of choice has been lactated ringers. I'm a big lactated ringers fan, but I think you can use saline. And where we really should be is trying to figure out this kind of question, as well as what should our protocols be when people come in? What is an adequate resuscitation? And we don't know that. We know what massive bleeding protocols are like, but we don't know what it's in most patients. And I think, and one of the reasons to use these risk scores is you may look at a patient and go, oh, they look pretty good. I don't think this is a big bleed. But then when you do their Blatchford, you may see it's 9 or something. It's pretty high. And you actually may not be aggressively managing this person initially. And then you sedate them, their intravascular volume gets depleted, and they crash, and you're wondering why this is happening to you. So I don't know the answer to you, but that's what I do.
Yeah, I agree with you, because I don't. After reading that, I got confused that even the guideline initially said crystalloids are better and colloids sometimes use it, but still there are no final answer. And Professor Vivek Saraswat, you want to ask something?
A couple of very basic questions again for John. And see, there's so many competing guidelines. If you go just through the last 10 years, there would be about 10 or 12 different guidelines for non-variceal upper GI bleeding. The European guidelines, the Asia Pacific guidelines, the NICE guidelines, 3 versions of the international consensus guidelines. So, and many of them have very common points. So is it not possible to have one latest state-of-the-art current guidelines, which people across the world who have very similar problems in these areas could follow? What are your thoughts? Should we just be following the latest guidelines and ignore the previous ones, or how do we go about it?
Yeah, so the latest guidelines always build on the previous ones. So they don't actually change the majority of information. They only try to tackle the information that is new since prior guidelines have come up, and they build on it. So if you look at the differences between guidelines, most of them are saying the same things with only some new, relatively new differences. And, there is, the latest international consensus said, I think it said the hemoglobin transfusion may be 8 rather than 7. And that's because they weren't sure of the data quality. And then I think it's going to go down to 7 because we do have higher quality data that's now available. But so the differences are relatively small. And I'll tell you, having been involved in the 2019 International Consensus Guidelines, we were meeting starting in 2017. We finalized things in 2018. It got published in 2019, but we're always 2 or 3 years behind. Having just finished the ACG guidelines, writing it, we started a year ago and we froze our data at that point, said we're going to do a review up to this point, and we're going to do a systematic review, a meta-analysis of any of the controversial points. But you can't, we go, what do we do when there's a landmark publication that comes out after that? So this data knowledge is changing, but a lot of the concepts are the same. So I'll go back to risk stratification scores. Just think, how many of you are using risk stratification scores? I don't know the answer, but I bet the minority are. It's been in all the guidelines in the last 10 years. All of them have said it. So, look at the data, think about your practice, and do what's in, the majority of these guidelines, and you're going to be okay.
There is always a disconnect between the recommendation and the practice. I think fewer than 10 or 20% actually follow recommendations among the practitioners.
Dr. Saraswat, we should have some guidelines before creating guidelines.
That is happening.
Pure implementation of guidelines.
Yeah, no, there are now uniform guideline recommendations of what quality of evidence that you include and how do you present that. So at least in our latest guideline from the ACG, it's all PICO-based. We ask a question, we look at the evidence, and we try to answer that based on the available evidence. And we, strategize what are the right questions and how can you ask those questions.
Oh, that's great, actually.
Yeah. And just one comment on John's statement. I think very important point that he brought up is that these guidelines and textbooks are typically 2 or 3 years behind present day, and practitioners need to keep that in mind. But also, guidelines are guidelines. They are not mandates. So as John referred to the legal cases before, if ever, due to circumstance, personal experience, situation at hand, you deviate from said guidelines, if you provide appropriate justification that is rational in the medical record as to why you did do or did not do a certain thing, you should be fine. And I think the problem comes is where people don't document, there's random deviation, and then you get into trouble. John, I know you couldn't cover everything there, but I think the audience and myself and panelists may want to know, what's your take on Doppler-based treatment of vessels? It's received a lot of attention in recent years, but Doppler-based management of GI bleeding, what are your thoughts on that?
Yeah, so Dopplers are fascinating. So Dopplers are probes that go down the endoscope, and you can listen to the vessels, and you can see after you've applied endoscopic therapy, have you gotten rid of that arterial signal? And that's the change in thinking is rather than use our visual stigmata to a Doppler-based stigmata that we've really gotten rid of it. You can also use Dopplers to detect bleeding vessels. You may look at an area and there's a bunch of little spots and you're not sure what's bled or what's a visible vessel, and you can go onto the Doppler and say, which one is this? I have to admit a bias in this. I helped to develop the Doppler about 15 or 20 years ago. It hasn't been a research interest of mine, but it's been a clinical interest of mine. And I've used it for at least 15 years clinically. And I'll tell you, the way I use Doppler is that I use it in lesions that I'm not sure I've applied good enough therapy or that are rebleeding. And that they really, I don't want to bring them to surgery again. It's very easy to use. It only takes a minute or two. The probes are not expensive. The equipment is not horrible to purchase, and I think makes a lot of sense. However, this is again an area where the quality of data is good, but not fantastic. It's not level A evidence. It comes out of a few specialized centers, and Dean Jensen at UCLA Cure Group has been the most recent one, although the literature goes way back. And people are not really willing to adopt this, even though it actually makes sense and it has been shown in all the studies, and there have been studies for 30 years, to reduce rebleeding in select groups of patients.
Thank you.
Dr. Gokul?
Yes, I have one question to Professor Salzman. So you have devised the AIM-65 scoring system for scoring system. In that you have these parameters like albumin, INR, and altered mental status. Are those parameters actually specifically intended for patients with liver disease, or it is for general patients?
Yeah, so I think I didn't hear all of your questions, but I think it was about the AIM-65.
Can you unmute yourself?
No, somehow the microphone is not.
Can you unmute Dr. John?
Oh.
Huh?
No,
we can hear him.
Yeah.
We can hear
So
him,
I think the question was about
Dr.
the
Gokul's phone might
AIM-65
be on.
criteria, which includes INR and albumin, which I came up with as part of a prediction score for who's at high risk. Does it involve variceal bleeding or non-variceal bleeding, and where is the prediction greatest? Well, we know about INR and albumin in patients who are variceal bleeding. When I developed and I validated the score, it was in both non-variceal and variceal bleeders, and it worked in both populations. And then you'd have to look at the non-variceal bleeders, I think are the more interesting, at least in when we had over 30,000 patients of data available to derive this score. Albumin was the greatest predictor of mortality. The single greatest predictor is emission albumin. And if it was less than 3, it was a serious predictor. So, think about that in a lot of other diseases that we encounter. The albumin is so important, and it's a general indicator of, their state of health, as well as nutritional status. So I think it's applicable to both, if that's a short answer.
Dr. John, there is a question. When do you use Hemo Spray as your first choice? What are the conditions?
Yeah, so Hemo Spray is usually not my first choice, because I'm pretty good at seeing the source of bleeding and localizing it, and through a combination of things. And then I usually try other things and use it as a rescue therapy. I would use it as a primary therapy in somebody who's bleeding so much or has such a big vessel that I can't get that under control. I want to stop it. So I'm looking at a gastroduodenal artery. It's bleeding. I'm putting an epi to slow it down. I'm not slowing it down. I can't get control over this thing. Throw in some, Hemo Spray and hopefully stop it. If I stopped it, typically I'm not able to visualize it well enough to apply clips or other therapies afterwards, or an over the scope clip. I would try to go back the next day in that kind of situation and repeat endoscopy. I don't do routine second look endoscopy, but I do in select patients that.
How about tumor, diffuse bleeding from the tumor, gastric tumor? Or
tumor. Thank you. That is actually, I was thinking about peptic ulcers as you were asking that question. It's a wonderful modality for tumor bleeding. So before this was available, what I would use is use APC at a very high wattage. I basically ablate the lesion. I would be taking off a whole layer of it, and it worked okay. But I was very aggressive, and it wasn't sort of standard care. Now I'm using, hemostatic spray, and I'm amazed is that a lot of the lesions bleed from multiple sites, and they're oozing lesions. And once you get them to stop, they can stay stopped. The ones I've had troubles with are the ones where it's eroding into a large vessel. And those you may, temporizingly stop it, or you may not even be able to stop it in massive bleeding due to tumors.
I second that. For malignant bleeding, we haven't had any good options, and Hemospray is fantastic for that, at least based on what we have available. But to answer the question on monotherapy with Hemospray, it's beginning to look from the international registry, as well as data presented by the Hong Kong group recently, that it's at least non-inferior or comparable to standard therapy. So keep an eye out for Hemospray or similar powders monotherapy. It's emerging from the salvage and rescue realm to more and more use as monotherapy compared to standard therapy. So more to come on that, but it's looking good.
Right.
Yeah, I think you can use it as monotherapy. I just one comment about that. The randomized control trial that looked at this is that most of the active bleeding were FARS 1B lesions. They were not FARS 1A lesions. And we're going to see the full data. I know it's in press somewhere, but I had spoken to the authors about this. And so it can control bleeding acutely, but I really think you're going to need another modality in patients who have spurting bleeding in large vessels. And so it may be the
Yeah.
first therapy. I think you're
Yeah.
going to have to either do it at the same time or in combination.
But I don't disagree. And I think, but John, you would agree that we're still surprised to see how efficacious it is even with Forest 1 lesions, even though they're 1Bs.
Right.
I
Well,
wouldn't have initially expected even that degree of efficacy based
I
on
knew it works well. I think the last point I'll make is that it's very expensive in the United States. I don't know what it is in the rest of the world, but it's cheaper. In the United States, a hemostatic spray, it retails for about $2,500. And though there are discounts, there are probably nobody cheaper than about $1,500, $1,600 in the US. So, you know, clips are $100, maybe $200. You have to think about that. Now, obviously, any therapy that works and stops the bleeding and shortens length of stay and other complications is more valuable. But if it's the same, you know, you have an oozing lesion, you can treat with a clip or you can treat with hemostatic spray. I would treat with a clip.
So if all of us here, Dr. Oido.
One last sort of basic question for John. May I, TSC?
Yeah. Please carry. I didn't listen to it.
Yeah. No, I think you mentioned earlier, and it's been pointed out by the other panelists also, that the level of evidence in most recommendations is weak. In fact, if I look at the international consensus guidelines, many of the recommendations, the panelists either did not make a comment because the evidence was weak, or the quality of evidence led to the downgrading of the level of the recommendation. So what is the way forward? There are studies with thousands of patients. The numbers in many studies were not a problem. But the nature and the practice of GI endoscopy is such that getting level A evidence where every patient is almost identical to the next patient and every endoscopist is as good as the next is something that's unlikely to happen. So, I mean, it leaves you with a kind of a big question mark in your mind when the level of evidence and the quality of evidence is low. How good is this recommendation and should I follow it? So what is the way to overcome this kind of a stumbling block?
Yeah, I mean, I think this is a major problem in all of GI. And I think the only ones within internal medicine who have done a good job with this are cardiologists, and that they've had good international trials, multi-center trials. And what we need to do for a good trial is you need a population that reflects the population you're actually taking care of. You need endoscopists who are not expert endoscopists and expert centers doing cases. You need to have it a little bit more generalized. You need to have it internationally applicable and not just in one country. And you need to standardize the outcomes of things and how you're doing trials. So at least in the GI bleeding world, we have a manuscript that we're still preparing and press from a collaborative group. It's not the same as the international group, but many of the same members that we're trying to say, in moving forward, these are the endpoints. These are the primary endpoints and how you should define them in trials. We don't always agree on our endpoints of this. And then here are the secondary endpoints that we should be looking at, and this is how we should be designing it. So I think we need to come up with this, and then we need to work together. We can't all operate in our silos, doing our things and reporting our experience from Harvard and thinking it's going to apply to the rest of the world. We have to work together. And so I think that's the only way this is going to become high-level evidence.
Right. Thank you very much. I think TSC, back to you.
We have one more question. Before we take up, we have to switch gear to endoscopy imaging later on. We have 5 more questions. We'll give you a pointed questions. Now, multiple small bowel angioma is always a tricky situation, clinical scenario. So what is the best modality and how do you manage it? Right now, we have, if there's a bleeding lesion is focused or localized, then we can go for hemoclipping with enteroscopy or hormonal therapy. Is there anything advancement made in this area? Some questions.
Yeah, I don't think there's a lot of advancements. I mean, there've been advancements in, capsule endoscopy and visualizing the entire small bowel. There's advances in deep enteroscopy and our ability to get through the small bowel. So we can get to many of these lesions. When you see them, I typically use argon plasma coagulation, but you can clip them. There's a high rate of rebleeding of patients who have multiple lesions. And we don't know if it's the same lesion that's bleeding or did you miss one that's next to it that's now bleeding. And the value of medical therapy is not good. We've had trials looking at estrogens, we've had trials looking at creatine, thalidomide, but it's really not proven at this point that there's any value. So basically, if they're bleeding, I treat everything I see, and I hope for the best, and I hope I don't have to be back soon. I don't think there's any major advances.
Fantastic, Professor John. We are going to switch gear to endoscopy imaging. And basic question from a delegate from Kerala. What is the difference between high definition endoscopy, magnification endoscopy, and endocytoscopy? Professor.
So high definition means signal from the processor. So, how many pixels or something. So it is basically electronical resolution. And magnification endoscopy is optical magnification. So compared to electrical resolution, optical resolution can have higher resolution level. Important thing is how enlarge or something. Most important thing is how we can, resolute the very fine structure or something. So usually optical zoom is more important than electrical zoom. And endocytoscopy has a more higher magnification level. So conventional zoom endoscopy has a 100 times magnification, optical magnification. But the endocytoscopy has a 500 times optical zoom. Yeah, so one is whether it is optical, electronical, and the level of magnification. Yes.
So HT is more pixels. Magnification endoscopy is 100 to 150 times, and
Yes.
endocytoscopy is 500 times.
500 times. Yes, yes. Optical magnification.
There is a question to you is, there are studies available. See, magnification endoscopy is not available in major centers in India. Majority of it. And the cost is prohibitive. There are studies available. White light endoscopy with the NBI. The results are comparable to magnification endoscopy and NBI. And what are your views?
So probably a magnification and benefit of magnification NBI is we can evaluate microvasculature of the lesion. So usually conventional endoscopy, we evaluate color, difference of color or difference morphology. So maybe only change to NBI, just enhance the color, but that's all. But if we can combine with the zoom endoscopy, we can evaluate detailed microvasculature of the lesion. So on top of that, we can add diagnosis of microvasculature in addition to the difference of color or morphology. So that is a benefit of magnifying NBI.
And question to Dr. Vivek Kaul and Dr. Nalini, how many centers in USA will be having magnification endoscopy?
That's a tough question. I do not know the exact answer for that. I suspect very few, although most of the Olympus platforms do have what we call the near focus, capability. But I don't know the answer to that question. I think it's very, very few.
Very few. That means, are we missing early cancers? If you don't do, see, now it has become a standard.
But I think usually near focus or magnification is only for characterization. It's not for detection. Yeah. So detection is still based on conventional.
Right. That was about to say is that Dr. Chandra Shekhar, I think you raised a very important point, and this has been addressed in recent documents from the ASGE and from some investigators, is that the time spent in examination, particularly in precancerous disease states such as Barrett's, is really, there is no substitute for that. And that's where the examination under high definition white light, narrowband imaging, and subsequent interventions based on that examination are really important. I cannot tell you that we still find, interval cancers or findings on repeat endoscopies where an endoscopy was done recently and major findings were missed. So that remains a gap in education, in training, in practice. And I think that before we get, too much higher in terms of more advanced techniques. Basic techniques have to be mastered. And I suspect this is not an American problem. This is a transcontinental problem. And it goes back to all the basic issues that are being raised today in the discussion. Nalini, you have any comments on that?
Dr.
No, I
Nalini?
don't. I think, it boils down to spending time and looking at it. I think all the technology will only assist you, but the basic premise is that one needs to look at it, right, and identify, right, and then the technology will help. So there's no substitute for the endoscopist's eyes and the time you spend on looking at lesions.
Something related to the same thing, Dr. Nori, I want to know. I want to make it a little clear. White light endoscopy in NBI for the detection of early cancer. For characterization of the cancer, you need magnification endoscopy NBI. Is it right?
Yes, yes, yes. So for
Yes.
characterization, magnification is better. But for detection, conventional NBI and white light image, we could not find the difference, statistical difference.
Suppose I have a person who he spends time with the case and uses white light endoscopy and NBI. We will not be missing early cancer. These are the assurance I want from you.
So
I'll be very happy. I'll go to bed with satisfaction.
important thing is a good preparation and a careful observation.
Yeah, I'm done with the good preparation.
Conditions.
My boy is very patient. He wants to spend half an hour also, no problem. And I am using white light endoscopy. So I am feeling guilty that I cannot afford magnification endoscopy. My only thing I wanted to know is, am I missing early gastric cancer if I am not using magnification endoscopy?
I don't know. I'm reminded when I was a medical student and I was rounding with my senior staff, and he asked me to listen to somebody's heart, and I had the fancy cardiologist stethoscope, and I listened and I did not hear the murmur. And then he pulled out his stethoscope, which was a nurse's stethoscope that he borrowed, and he heard it. So it's not necessarily the equipment; it's what's between your ears, or not just what's your eyes. So you have to have the right training.
I do understand. But magnification endoscopy, now every literature, everyone says magnification endoscopy. That's the reason I want to raise this question. I agree with you. The man behind the mission is important. And the time the quality time is important. Dr. Saraswat, you want to ask some question?
Just to chip in on that, what I'd say is that you have to generate the evidence that these fancy approaches, these newer approaches with NBI, may be backed up or with or without backup from magnification endoscopy, do help in saving lives, saving organs, saving money. Once that is established, and then you get people to be paid for spending their time and get recompensed for the amount of time they spend in finding early gastric cancer, early esophageal cancer, that is when you will be seeing mainstreaming of the equipment and the technology, and based on then eventually reimbursement and similar steps. So we are moving in the right direction. The Japanese, as usual, are way ahead, streets ahead on this. But the payback is going to be once you have enough literature and evidence to say that using these techniques, you are not just saving lives, organs, and also money. So I think we are a bit still some distance to cover to reach that point. Would you agree?
Dr. Gokul, we have 5 more minutes and we are going to. We have 5. Okay.
Sir, I have one question to Professor Oido. You have described this light blue crest sign in intestinal metaplasia. What's the sensitivity of this sign in identifying metaplasia, and what is the reason behind the color, the light blue color that happens in intestinal metaplasia?
So according to my data, sensitivity is almost 90%. And I think only meta-analysis of observational study, but also meta-analysis show almost 80, more than 85, close to 90% of sensitivity. So, and the reason why it looks light blue is I cannot explain in English, but it really reflects the short wavelength light it reflects the short wavelength light at the ciliated structure, microvilli of intestinal metaplasia. So that is a phenomena, mechanism behind the phenomena.
Thank you.
And I have a question to Professor. There's a question asked, EMR versus ESD. How do you decide with advanced endoscopy imaging?
So I think it is not depend on the advanced endoscopy imaging. So it's depend on the like a size or possible histology, like suspicious for invasive or low grade or something. So usually we decide the indication between EMR and ESD according to size, because the small
Very well.
lesion can be removed
The
unblocked even with EMR, but the large lesion we cannot completely remove.
But the depth of invasion, how will you find out with the advanced endoscopy imaging? Upper
So
method and the
so
middle
far
method.
So far, there is no evidence that advanced imaging is useful for prediction of depth of invasion of aligastric cancer, depth of invasion of squamous cell carcinoma. That is very useful. But for aligastric cancer, it is not useful for prediction of depth.
Not useful.
Not
I think
useful.
we are coming to the end of the webinar. I think
I have one
Professor
question, Dr.
yeah.
Oido. I know it is midnight for you, or past midnight. So if
Yes.
you listen to John's lecture, you don't need to wake up in the night for a GI bleed, right, John? For 6 to 8 hours, he should be okay.
Right.
All right, so we can sleep better. Second question, John. I think one of the audience has asked, if you see an ulcer that's bleeding, and you've taken your time, you control the bleeding, you then go ahead and biopsy same session, look for H. pylori.
Yeah, I don't have any problems biopsying at the same time. I don't think we're increasing our risk ratio. There are some reports that the sensitivity of diagnosis of H. pylori is lower during an acute GI bleed, so that if the biopsies are negative, I don't say that that's necessarily 100% right. So I will go back, and at a later point, if we have another endoscopy, I would biopsy him, or I would do a follow-up breath test after the bleeding episode, again, in a couple months, just to be reassured that that's correct. But I have no problems doing the biopsy at the time of the therapy.
But if negative, you consider
Yeah,
rechecking. If there's positive, then you're good. You go ahead and treat. Okay.
That's right.
Great. So it has been my honor to participate in this session. Dr. TSE, thanks for organizing this. I'm not concluding it. Conclusion job goes back to Dr. TSE, but I wanted to thank everyone.
Yeah, actually, it's a wonderful concept. I thank that. How did I get this idea? Because I always love to, whenever I go for rounds in PGH Chandigarh, so they always insist on evidence based. Who has reported this? What is the landmark of publications? So since the time I'm really obsessed with the landmark publications, and I like that statement made. Dr. John made it. You want to know the present concept, you have to know about your past, how it has evolved. It is fantastic. I loved it, and we must be very thankful to all the moderators. Excellent. Actually, Dr. Vivek and Dr. Nalini did a fantastic job. Professor Saraswat handled the entire moderation, and I mean, very interestingly, and the talk given by Professor Oido first, that has really created a great impact. Great impact. Now everyone is going to have a suspicious eye from tomorrow onwards, whether it's a malignant person or benign person, or what is the potential inium, and whether is a surface pattern is irregular or is a vascular pattern is irregular. And I only think surprisingly you did not mention about Kudos Pitts classification. No?
Yes, because I mainly focus on equipment-based image enhancement. So we did not include, chromo-based image enhancement. Yeah.
It's a Kudos
That's
classification,
why.
the one created
It's
impact. The polyp, whenever we see polyp, we always think about
of course.
Kudos. So the Kudos classification, that's the only thing. And the lecture was fantastic. The 10 publications really is mind-blowing, and it's a great eye-opener, and we really loved it. And it's going to create an impact in this webinar. And Professor John, 10 publications, and the way you put it in the chronological order, and the way you took it from the how, and the summary slides is fantastic. How you evolved from these 10 publications, and you brought it to the summary, and the timing, and the what kind of therapy, and the restrictive the resuscitation, or all kind of things was really fantastic. I do agree with Professor Saraswat. Why you limited to 10 publications? At least let us remember first 10 first. So I think that 30, I can't remember beyond that. So I think 10 publication. And when I'm making a book, I would always include the studies related to the 10 publications also. Your advice is well taken, and I am very thankful for the ACG for endorsing this webinar. And before Dr. Gokul gives the official the vote of thanks, do you have any other burning question to ask?
No burning question. I just would like to reiterate what all the panelists and the speakers have said, that this has been a fantastic session. Where the 2 hours have gone, I couldn't realize. I thought we were just kind of warming up with the questions, and you find you are now out of time for the session. For people to be engrossed and gripped by the topic for 2 hours at a stretch is a huge compliment to the speakers and the panelists and the format. And yes, this novel format is now you're going to have to come up with something much better than this next time around. Now, what's going to be better than 10 landmarks, TSC? Once you're finished number 8,
the bariatric therapy and GRD in endotherapy. We have Pradeep Sharma and Dr. Manuel from the Brazil. One thing, all the delegates have written, fantastic speaker, nice concept, and very clear-cut concept. Both the speakers are given. That's a general comment. Only thing I want to ask both the speakers is, how much did you enjoy? How much did you find it difficult to prepare this topic? Have you ever given this such topic earlier?
Well, I'll say for myself, it was very enjoyable to put together this topic. I've never thought of it in this way, but I know about these studies and I've used them, and it gave me an opportunity to go back and think critically about the field that I know so well as read the original papers again, which is always sort of a joy to go back and actually look at those original papers. So it was not a lot of work really, but it was very enjoyable to me.
What about Professor Noria?
So I explained that I was recently involved in some, committee member for creating a guideline for image enhanced endoscopy. So not so difficult for me to prepare. And also it's good for me to update new information. So thank you very much.
You know why I asked this question deliberately? Both of you are involved and in the guideline making. So you will not find it difficult at all. Suppose a person who is not involved, that's the reason you are the stalwart and you added value to this webinar. I think now every good thing has to end somewhere. So now Dr. Gokul is going to offer a vote of thanks.
Now it's my pleasant job to thank each and every one of you. I thank you all for this wonderful evening. It was truly an academic feast for all of us. First of all, I'd like to thank my chief, Dr. TSC, for not only having conceived this idea of landmark publications in gastroenterology, but also for having invited the stalwarts in this field as speakers and panelists, and also for getting these programs and future programs endorsed by the ACG. I would like to, on behalf of Medidia Hospitals, I would like to profusely thank Professor Salzman for his excellent deliberation, for having consented to our invitation, and for his non-ambiguous presentation on non-variceal bleeding. Thank you, sir. It was truly inspiring to know about the semantic work done by the giants in the field of GI endoscopy. It was a pleasure listening to you today. I also profusely thank Professor Oido for accepting our invitation and for enhancing our knowledge about the image-enhanced endoscopy. We all understand it is late evening there at Osaka, Japan. Thank you for staying back, sir, and for taking up all the questions and for actively taking part in the discussion. Thank you very much. I would also thank our stalwarts and panelists, Professor Nalini M. Guda and Professor Kaul, for their insightful inputs and for making this interaction very interesting. I also like to thank Professor Vivek Saraswat, President of our Indian Society of Gastroenterology, for his active participation and also for his sharing his thoughts and wisdom on these two topics. Thank you very much, sir. This program would not have been possible but for the unrestricted educational grant from Microlabs and my Microlabs Knowledge Academy. I'd like to thank Professor Mr. Jayaraj and his team, Mr. Shwakshar and Mrs. Pranita for their assistance and support. I also thank my colleagues, Dr. Prasad, Dr. Satyamurthy, and Dr. Yogesh, and our technical staff, Mr. Sivanandam, Mrs. Selvi, for their inputs and support. But not the least, I'd like to thank all the participants for viewing the session. I'm pretty sure they would have immensely benefited from the scientific deliberations that have happened today. I thank you one and all.
And you're all invited for a virtual dinner now.
Thank you very
You're
much.
all invited for virtual dinner.
Right. Thank you very much. Great pleasure. Wonderful
Good
job.
night. Good night. Good night.
Thoroughly enjoyable.
Oh,
Bye-bye.
okay. Thank you.
Bye, guys.